just mute everyone. So, welcome everyone to this, the Foundation Group 3 board meeting. We've had an interesting morning this morning talking about the urgent and emergency care winter and recovery plan with Sarah Jane Marsh. And we've also had a session on one of our big moves as a foundation group, which is to ensure that we embed prevention in everything we do. With so many people on the call, can I just please say again, can everyone please be on mute, and can everyone please ensure that their cameras are off? Just before we get the meeting going, there's just a few points I want to make by way of introduction. The first is today is the second day since Worcester Acute have joined the foundation group as full members, with Glenn and I becoming chair and chief executive respectfully. I just want to open out the arms of friendship of all Worcester colleagues to the foundation group. We're very much looking forward to sharing our journey on the foundation group with all of you, so welcome. The second is a vote of thanks, particularly to my executive director colleagues. I am very conscious with all of the strikes and disruption that has been going on, that you've had to cope with an enormous amount of uncertainty and challenges as you've had to crisis manage the short term whilst addressing the need to still continue to see improvements of our journey towards getting to a better place. So I do want to really thank all of my executive director colleagues for the phenomenal efforts you've been going through. I'll just say again, can all colleagues, apart from Glenn and I, please turn off their cameras? The final point I just wanted to make before we get going with the meeting is an enormous vote of thanks to all of our frontline teams during the period of strike action that we have all been having to cope through. I'm enormously grateful, and as I know all of the board are, and frankly our citizens are, for those who have continued to come to work to help ensure that we are minimising the amount of disruption to the citizens we serve. And I know the very practical challenges of the cost of living are affecting all of our colleagues. And so I do just want to recognise that again, but the level of uncertainty of these strikes really does cause very real problems. So thank you to all of our frontline colleagues in the meanwhile. I'll say again for the fourth time, can all colleagues please turn their cameras off and please allow them all to be muted. Thank you. So we'll get going with the 3 board meeting. So any new declarations of interest, would you please raise a digital hand if you have any new declarations of interest? Okay, I can't see any digital hands, so I'll take that as a no. The minutes of the meeting held on the 3rd of May, so the last time we had a foundation group board meeting. Jenny, can I ask you to turn your camera off, please? So first of all, the George Eliot minutes of the meeting held on the 3rd of May. For George Eliot directors, if you're not happy with the accuracy of those minutes, could you please raise a digital hand? Okay, I can't see any digital hands raised, so I will take those as an accurate record and will duly sign. For Swift directors, the minutes of the meeting held on the 3rd of May, if you do not feel they were an accurate record, could you please raise a digital hand? I can't see any digital hands raised, so I'll take those as an accurate record. From Swift colleagues. And finally, Wye Valley colleagues, the minutes of the meeting held on the 3rd of May. If you did not feel they were an accurate record, could you please raise a digital hand? Again, I can't see a digital hand raised, so thank you very much. I'll take those as an accurate record and duly signed. So we're then on to the Matters Arising and Action Update report, which is page 34, I think, of 125 in our pack. And I think there was only one, which was the Group Analytics Board to include services data as part of their future project work. Hack, can you just brief us quickly on where we are with this, please?
Yes, Chair. So as part of the update later on, I'll be talking about kind of the next steps for the Group Analytics Board, and I'll pick it up as part of that, if that's okay.
Okay, super. Thank you very much, Hack. Okay, so are there any actions arising that I've missed? Okay, again, can't see any hands. Next on the agenda is the overview of key discussions from the Foundation Group workshop. I think I've covered that, Glenn, but is there anything you wanted to add?
Yeah, if I may, just to, I mean, I think the format of these days now we've got into a good structure of, so the external speaker drilling down into some of the strategic big moves in the workshop, and then obviously what we're about to do now, some of the performance comparative data across the group. I think it's particularly good to hear Sarah Jane this morning, because her grasp of the wider issues around A&E performance, and really good that we all received the winter letter last week. So that's the first time it's ever been received during the summer. And that has specific job cards for all organisations in integrated care systems, including mental health colleagues and social care colleagues, as well as what the system itself can do. So we're in this process now of pulling together those winter plans, which should be really founded on the plans that already exist for urgent and emergency care and systems. So really good to hear, particularly the focus on frailty and not admitting those patients unless we absolutely need to. And then the prevention session I thought was great, in that it's reminding us of the need to make sure that in this frenzy, particularly as we go into winter, that we're suitably investing time and resources into prevention, and that there are some shorter term impacts of prevention. So readmission, patient education being an example of that, and supporting patients after discharge, but then also using our anchor institution leverage to change things like housing, like education. So that was really good to see, and there's some great work going on across the group. And like you, it's great to have Worcester Acute colleagues joining us today. Next time we do this, they'll be fully alongside us and in that data pack. And so one of the things that Hack and the Group Analytics Board will pick up is making sure we've got Worcester Acute input into that, and then we can therefore add that comparative trust performance to our overall pack. That's all I wanted to say. That's okay.
No, that's great. Thank you, Glenn. And I think the other thing for our partners within the places that we operate, we are very conscious that particularly our council colleagues and local authority colleagues do an enormous amount in terms of prevention, and we need to work more closely with them and support them in the challenges they have of driving forward a more population health management approach, because early intervention, ensuring there's a better start to life and better life outcomes, will help the NHS save an enormous amount of money going forward. So it's enlightened self-interest to work with our council colleagues and our education colleagues as well. So if there's nothing else to add on that, we'll move then into the performance review and updates. And for members of the public, and maybe for Worcester Acute colleagues, what we do here is use our comparative packs to pull out key points of comparison. One of the great strengths of the Foundation Group has been the way we've been able to challenge one another and learn from one another to identify and share best practice at pace, so that we overall drive one another forward and support one another forward in our improvement journeys. So who wants to go first? Lady Jane, over to you.
Yes, we were going to go in the order in which we appear on the paper. So thanks initially, Russell, for your opening remarks and your acknowledgement of the difficulty that we're all facing with the industrial action in particular. And we've got another junior doctor strike next week, a consultant strike 2 weeks after. They take enormous time and effort from our clinical teams, our clinical leads, and our management teams, and it does get in the way of us trying to do some of the improvement work that we're trying to do as well. So thank you for that acknowledgement. I'm going to pick up sort of something not very good, something that's improving, and something that's good, to try and give a flavour of the Wye Valley side of things, and as you say, pick up some of the things about where we're learning from each other. I was going to start off around ED, and also we've had a number of questions from a member of the public around ED performance, and particularly around Wye Valley. So I'm going to try and pick up the answers to those as I go through. So obviously the Herefordshire continues to really struggle with ED performance. Although again, if I particularly for members of the public, other people who have heard me say it before, if we look at type 1 performance, which is just A&E alone, as a comparator, actually Wye Valley is about middle of the pack regionally, nationally. However, it's not as good as George Eliot or Swift, and so one of the things that we're doing is we are doing that swapping across of teams, learning from each other. There's been a visit across to George Eliot recently, and there's further work going on with Swift, making sure that we're learning the lessons, although everybody's system is different. But it is a significant concern for us, and actually particularly this week and last week we've seen even more pressures. We're very much in a winter scenario at the moment. Last night we had 22 patients boarded on our wards. We had 23 patients in A&E waiting for a bed this morning, which is much more of a winter scenario. There's a whole range of reasons for that. But a significant one is we've had a very big increase in emergency demand. So we are admitting 20% more emergency patients this July than we did 12 months ago, and so that increase in demand is part of the picture. So the improvement work that we're doing, the context of this is we've agreed an urgent care blueprint for Herefordshire, which is really a map to take us through how we're going to transform urgent care right across the system over the next 2 or 3 years, and that includes how primary care is accessed as well. So that's our guide with the work that we're doing. But the work that we're doing is really across 3 areas. So pre-hospital, so that's very much around urgent community response, but it's also about social care and access into packages of care for people waiting at home, so that they don't deteriorate and end up having to come into hospital. Lots of work going on in hospital, and we're finalising our plans to round about triple the size of our same-day emergency care area. And so by the beginning of September, that should be in place, and that will make a big difference, along with making sure we're clear about professional standards for all of our areas and how they respond to emergency care. And then in terms of post discharge, we're going through a process of redesigning all of the discharge to assess pathways and making sure that they're really productive and they really flow, because we're not getting as much out of that investment through the Better Care Fund in out of hospital discharge services that we should be getting, and that's something that we're working on jointly with the council. So a huge amount of work going on, but we're not in the place that we want to be. But we recognise really the next 2 months is the window of opportunity that we've got before we start to move into real winter pressures, as I say, although it feels like that is now. So that's the area that we're most concerned about. In terms of improving, the place I would draw attention to is around the 28-day faster diagnosis standard. That's for from referral from GP to getting with a suspected cancer to getting a diagnosis one way or the other within 28 days. That's really been improving. and our teams think that really by the time we get to October, we should be in a sustainable place with the 28-day faster day standard. That's really important for patients, and it's really important for clinical outcomes. And then the area of good practice I wanted to highlight was around the sickness levels. There's been a huge amount of work that's been going on over certainly the last year, but before that as well, across our operational teams, our HR teams, our management teams. But this is really all about making sure that we're looking after our staff well. And we have seen really sustained drops now of our sickness levels, and July's come in at the same level as the June that's reported on the board papers. So that's the lowest level, certainly the lowest level I've ever seen in Herefordshire. So I don't go further back than about 6 years now. So some really good performance there, looking after our staff, because we're not going to do any of the things that we really want to do unless we've got staff at work and well. Okay.
Okay, super. Before we move on, just any questions or perspectives? Glenn, you wanted to raise a question about ESDEC?
Yeah, thanks, Russell. And it's good to see the level of performance on ESDEC at Wye Valley, and I know you get a lot of regional attention for that, which is good. You just referenced the fact that we're going to create more space. What's the view as to how much ESDEC we ought to be aiming to do? And the follow-up to that is how are we ensuring that's protected during peak demand period so that we don't compromise its capacity?
Just before you answer, Jane, just again for members of the public, ESDEC, same day emergency care. Jane?
So how much? As you say, we're generally now around about that 40% level. I would be surprised if we don't get an additional 10% on that. The areas that we're putting into that is our frailty ESDEC. We've tried to do that by protecting a bay on a ward for frailty ESDEC, but we haven't been able to protect those beds. And so it's been there and then it's not been there, and so it's not been a sustainable service in that way. So actually putting it into a protected area is a big advantage. So that's one area, and we're also putting surgical ESDEC into there as well. So again, we use our current ESDEC for surgery, but it really isn't big enough to deal with all of the specialty patients. So we should see an expansion of surgery as well. In terms of protecting it, I mean, it's currently is protected because it's in an area where you couldn't physically get a bed or a trolley into. When we move it, we will be able to physically put a bed or a trolley into. So it'll be about operationally making sure that we are ring fencing it so that we've got space for the next day, because the worst thing we could do is to fill it with inpatients. It'd be counterproductive. So we will physically be able to do it, but it'll be our intention not to ever do it.
Okay, great, thank you. David Mowbray is asking the question, if we can answer in the chat box, about an increase in surgical acute admissions. Any other questions to Jane before I move on to Adam? Okay, Jane, you have our understanding at the moment, because the volume of demand coming into you is quite extraordinary. So keep the faith. And let's just keep on grinding away. Jeffrey and team, and I know it's not just Jeffrey and his team, but really great work in terms of sickness. You're leading the way on that, and as Ian has put into the chat box, all the trusts are below the national and regional averages, so well done everyone. So Adam, what would you care to pull out of the SWIFT part of the performance report, please?
Thank you, Chair. I'm going to start with ED performance as well. So last year I think was a challenging year for ED performance, and we'd seen lower rates of performance than in previous years. So we really started this financial year with a focus on establishing our ESDECs and a focus on flow in the hospital, and I think that really paid off. We had a fantastic month in April. and May and June were again near enough at and above the national target. I think the really important context to set that in is how busy we were in May and June. So May was one of our busiest ever months. We thought it wouldn't be surpassed, and then it was immediately surpassed in June. And in fact, we had our busiest ever day with 378 attendances in June. And I think when you go back a few years, a busy day was sort of in the low 200s. So I think that really shows the increase of in the demand on ED, and I think fantastic work by the teams, not only in ED but actually across the hospital in keeping that performance, maintaining it and improving it during those really busy periods. I think 12-hour and ambulance handover times have also been really positive. The biggest challenges are that increase in demand now, and in fact the inconsistency we're seeing. So we tend to have very busy days followed by very quiet days, and obviously that makes managing it quite complex. We are also seeing a significant impact from mental health patients who get stuck in ED. We've got a couple in our ED who've been there for a long time today, and this is becoming an almost daily occurrence. I think it's having a significant effect on staff in ED, and is an ongoing concern that we are working with ICB colleagues on. I just want to mention medically fit for discharge rates, and I know we've also got a question from a member of the public on this. So we have seen an increase, and it is an area we're focusing on. We've got a targeted approach to focusing on criteria to reside, and we're initially doing a really focused piece of work on one ward to make sure we're tracking coding and appropriately responding to the challenges. And from there, we intend to do a phased rollout across our other wards. I think it's really important also to mention the impact of the Warwickshire Community Recovery Service that we've been working with social care on. The implementation of that service has seen a really significant decrease in pathway 1 exit delays from Warwick Hospital. And while it's early days for that service, we're about 3 months in, and I know the review and analysis is still ongoing. It really is showing some benefits, and I hope we'll continue to see those as the service grows and adapts. Just to mention cancer performance, I think this has been a concern and remains a concern for us. I think in particular over the last couple of months, we've seen a significant increase in 2-week waits, 2-week wait referrals. It was high in June, as the report shows, but it was higher in July, which in fact was our busiest ever month. Despite that, I think one of the areas we're most proud of is the improvements in our 28-day faster diagnosis performance. We've had a real focus on that with the teams, and have done a lot of targeted work in fact with UHCW, and provide our oncologists to improve the time to that first oncologist appointment. And we've also seen an improvement in our patients waiting for more than 62 days. There's definitely more work to do there, but some of our specialties, particularly breast, I think are doing really well there now. So that's a really positive story. Just to end on another positive, we've also seen a reduction in sickness rates. And I think part of this is about our focus on being a very flexible employer and supporting staff well-being. Alongside that, we've really focused on our HR procedures. We've reduced our vacancy rate, and we've improved our time to hire. And I think we're seeing a really positive impact of that on our services, and in areas like ED, where we knew there were significant staffing pressures. So I think all of that is contributing to good performance in those areas.
Adam, great. Do you just quickly want to mention the fact that we've been identified as a GIRFT elective hot hub?
Yes, so really good news this month. I think we were the first acute site that has been given the elective hub accreditation, where the elective hub is effectively part of the wider acute. So I think that recognises the good work we've done on elective care. We've got the Vanguard on site now, which is increasing the number of T&O procedures we can do. So great stuff. And I know I know there's going to be challenges along the way with some of the further faster work, but certainly over the last month, the work we focused on with TNO has been really great.
And again, just before I invite questions, talk to us a little bit about the going further, going faster work.
Yeah, so the going further, going faster work intends for us to eliminate waits over 52 weeks by the end of the year, which obviously goes beyond the national standard. Harkamel and her team are doing a fantastic job with this. So we're in some specialties up to and beyond 111% of our elective activity, and actually it's been a positive story across the group. I know Catherine and Jane teams have been working equally as hard on this. Good work so far. Lots and lots of work to do, and I won't panic Harkamel by committing any more than that, I think.
Super. So any questions or perspectives to Adam? Glenn?
Which prompted me to think about something. So we had a group meeting with the GIRF team yesterday to talk about going faster, going further, and that was really reassuring to see how we're performing against the rest of the pack on that one. But interestingly, the patient-initiated follow-up performance. It's good to see that pathway, which potentially patients could have seen as a bit of a negative, that we're not following you up, we're asking you to come back to us if you need follow-up, is not resulting in lots of patients coming back to us. So I think we're getting to a position where we're advising patients more clearly on what they should expect post-operatively, and not needing that check back into the acute part of the system. And obviously they've got primary care to support them as well. So I think that's been a reassuring metric to keep an eye on.
Okay, great. Thank you, Glenn. Any other questions to Adam? What's worrying you most, Adam?
I think increasing demand and money are probably my two biggest concerns.
Okay. So, Swift are doing well in terms of elective. Catherine, do you want to give an overview?
Thanks, Russell. Well, I'll start in the order it is on the screen. And I think the beauty of us working together like this is how similar the challenges are that face us all. And the picture that Jane described facing Wye Valley this morning is the picture facing George Eliot this morning, that we find ourselves in summer, and whilst it's chilly, it wasn't chilly in June when we were looking at this data set. So, and the word Sarah Jane Marsh used this morning when she was talking to us about the plans for winter is that the performance across the NHS at the moment for the summer was fragile. And I think that was a really good word to use. So the metrics that you see here are sort of hard won in what seems like difficult times. So although we're meeting the national target for the 4-hour standard there, that is lower than we might really want to be seeing at this time of the year. And as the George Eliot board members know, the biggest challenge that we have around that is our bed occupancy of 100%. And it's also compounded at the moment, as you see, we've got the highest sickness rate in the group, and that's causing some additional challenges for staff. So it's difficult conditions for people to be working in. However, despite that, still doing great performance on the 1-hour ambulance delays, very few of those. And the teams work really hard, and it would be remiss of me in the first public board since the CQC announcement that our emergency department was rated good. And the team were rated good for well led and good for responsive and safe. So that's been really well deserved and very hard to achieve in difficult circumstances. Our challenge on the board there, when you look at it, is the cancer faster diagnosis standard. The teams have been doing a lot of work about that. The George Eliot board will know that I have been saying that by the end of the summer we will see an improvement in that. That's May's data, so come to June's board and we have done a lot better in the June figures that aren't yet in the public domain. but that's a really important group of patients for us not to lose sight of, because the anxiety associated with a potential cancer diagnosis is really not acceptable to be at that sort of level, and that's why that's such important work and why such a lot of work's been going on in that. And then in elective recovery, low numbers of patients over 52 weeks, working very hard with Jane, Adam and others in the GIRVed work to try and improve and learn from others and one another and others around the country in terms of what more we can do there. June was a good month for us in terms of elective recovery for inpatients and day cases, delivering over and above our ERF target. And then finally, I think the thing that I would say about medically fit for discharge, so we have lower numbers compared to the others in the group for medically fit for discharge. And I would also echo what Adam has said about the community recovery team across Warwickshire and the work that has been done between us in the NHS, Swift and George Eliot, and Warwickshire Social Services. It's been a really good collaborative working integrated care that has led to a reduction in our medically fit for discharge patients. I guess what I would say is, in the summer, with a relatively low medically fit for discharge number and a virtual ward open, that just gives you an indication of what I think faces everybody in the NHS as we move forward into the winter months.
Absolutely, Catherine, thank you. I'll come back to that. Any questions or perspectives to Catherine? David Mowbray, excited about your medically fit for discharge, Catherine. I'm sure you'll be pleased with that. Glenn?
Just a couple of observations, if I may, Russell. One on the sickness. Actually, when you look at the staff mix by trust, I think the one thing we should note with George Eliot is that we do employ all of our hotel services staff, whereas at Swift and at Wye Valley they're outsourced. And if you look at that staff group, they're slightly higher. So we probably should just note that there's something Maslow's hierarchy of need stuff in there, I think. But probably worth a look at the AHPs because they look a little bit high. I think that the 2-week wait referral data comparison between the trusts, though, is the one that struck me, which I think is worthy of further analysis, because obviously there's a big increase around Swift, which looks quite a lot higher than the per capita numbers we're seeing elsewhere. So I think there's a question mark about why that is. And then I'd probably question Wye Valley as to whether we are seeing urgent care diagnoses of cancer through A&E attendance, because it doesn't look like we're seeing the level of 2-week wait referral that we're seeing elsewhere. So I think it's one for us to have another look at another point. And maybe if we looked at individual tumour sites, Russell, it might be interesting.
Okay, can we take that away as an action point, guys? That would be good. Any other questions or perspectives? Julie? Julie, just before you ask your question, thank you very much. I mean, Julie, bless her, is suffering from COVID and the debilitating effects of COVID. So, Julie, thank you for your fortitude in joining the board this afternoon. Julie, your question, please.
Thanks, Chair. Catherine, thanks very much. And all afternoon we've heard, I suppose it's for all three, a few relays. We've heard the absolute figures, and there's a lot of commonality about the demand for in particular. But I just wondered if you could give us some reassurance or some assurance as three boards around how we're making sure that patient experience is maintained throughout these very difficult times. So what are the areas where we actually can give ourselves that assurance around patient experience? Sorry about the throat.
No worries, Julie. What I'll do is I'll ask each of the MDs that question. Jane, how would you reply to that?
Yes, I mean, there's certainly a lot of effort put into that in terms of making sure that staff are really focused on where patients are, even if they're in a boarded patient on a ward, that we've increased the amount of staff that are available, so we've got enough staff to care for them. But I don't think we should be under any illusion. I mean, when we're under this sort of pressure and the hospital is so congested that there will be impacts on patients' experience. You know, their dignity is going to be very difficult to maintain if you're being cared for, you know, as the fifth patient in a bay or even on a corridor in ED. So there will be an impact on patient experience. It's really around, are we doing everything that we can to mitigate that as much as we can? And I've certainly from the senior nursing teams, that they're really focused on that. But you're on mute, Russell.
Thank you. I just guess on behalf of all three boards, just building on Jane's point there, to apologise to our citizens during the strikes, given the level of demand we're experiencing. We apologise if your experience has been less than you would want it to be and less than we would like it to be. Our performance may be better than others, but it's still not good enough. So I apologise, Adam, we would recognise it. Adam, how would you reply to Julie?
I think a very similar answer to James. We learned a lot last winter when we were experiencing some of the real pressures and challenges with flow in the hospital, where I think some of the conditions were not as good as we want them to be, and that had an impact on patients, I think, particularly in ED. Fiona Burton and her team are really focused on this, though, and I know our senior nurses are out there every day in ward areas in ED, making sure that we are doing all we can, making sure we have got our safe care standards in place, and really focusing on our quality priorities. But it is tough when demand is high, and there are times where the experience is impacted.
And Catherine?
Yes, I think I'd say the same. So when we do have extra patients on ward areas, all of those areas of risk assessed, the patients are risk assessed, and that we have, you know, regular checks in terms of making sure that patients are cared for in a safe and as dignified as possible way, accepting exactly what Jane and Adam have said, but it's not the same as being in as a designated bed space on a ward. I think, Julie, we can take some, if you think about the emergency department, the George Eliot Emergency Department patient survey, we've had some really good feedback in that, fifth in the country in terms of patient experience. So I think we have to pay testament to our teams who go above and beyond to really make sure that patients are still receiving high levels of care despite the pressures. And I think, obviously, we know as we go looking forward to the winter, we are going to have 2 extra wards delivered on the George Eliot site, and I really hope that that will be something that really ensures that our patients are treated in the right environment every time. But there's no doubt that when you've got such high levels of demand at the moment, that it will still be challenging in every organisation come the winter, and we've got to keep focusing on safety and patient experience and care as our primary concern in everything we do.
Thank you. Any other questions to Catherine? Okay, so just before we move off this, I just want to build partly on what you said at the end, Catherine. What leadership is about, it's easy to be a leader when things are going well, and life is rosy. That's the easy bit of leadership. Leadership is tough, and I'm speaking to all the EDs here. Leadership is tough when things are tough. But the one thing I know we are all in the same place as a foundation group on this is that we're not helpless. There are things that we can do in terms of agility and thinking differently. There are ways we can learn from one another, and there's ways we can support one another across the foundation group when we are suffering from particular challenges. So I think our mindset as an executive team is absolutely critical. I know, Jane, in particular, you're going through the fire as a team at the moment, given the level of demand. Our thoughts are with you. But I know you will, as ever, be determined and relentless in working through the issues diligently to find the best possible solutions. Well, on occasion, when there are no good solutions, It's just the least worst solution. So thank you very much for your continued endeavours. But the one thing we can never allow ourselves to do as a foundation group is to get into a defeatist mindset. We're not Harry Maguire. We're not a group of Harry Maguires. Glenn laughs. We need to be painful as it is to me, we need to be Manchester City and find solutions to the challenges we have. And with that sad thought as a Manchester United supporter, we'll move on to the group analytics update, and over to you, Adam and Hack.
Okay, I'll start off, and Adam can sweep up anything I miss as I go through this. I'll draw out 3 kind of key points from the paper, but first I just wanted to formally thank Jane Ives for her leadership and support in chairing the Group Analytics Board over the last kind of 15 to 18 months or so. And I personally really greatly appreciated her support and direction, so I just wanted to put her thanks on record. And also you can see Adam on screen, who is the new chair of the Group Analytics Board. So I want to welcome Adam, and looking forward to working with Adam on that. So I'm going to talk about the work to date and what we've achieved so far, but also about next steps, what we're going to do over the next few months and years, but and also talk about some of the challenges and what we're doing to address those. So in terms of very briefly the work to date over the last 18 months or so, we've focused on infrastructure, standards and standardisation. So what do I mean by that? On infrastructure, we've implemented Power BI across the group, which is a analytics reporting tool that allows us to automate much of our reporting and provide a better user experience, including user self-service. In terms of standards, we've implemented data quality kite marks. It'll take a while to roll out, but that is about making sure we're comparing apples and apples across the group and our data is of a good standard. Standardization, we have the group performance report that you've just looked at and talked about in the previous agenda item. We've standardized the IPRs across the group, and we're working on standardizing the monthly performance packs as well. So that's what we've done, and kind of that's not everything we've done. That's a brief summary of what we've done. There's more in the paper. Over the next 12 months, so what we want to focus on now is some of our kind of more strategic element of our strategic objectives around culture and focus on creating an information-led culture. And that, as I said, is part of our original strategy. It is one of our strategic analytics objectives. So how are we going to do this? We're going to run some workshops starting in September, involving a range of people across the group to be able to come up with what an information-led culture looks like for us going forwards, what it actually means for us, and what do we need to do to be able to get there. Within those workshops, we'll also include consideration of inclusion of services data as well, which is the action you referred to at the beginning of the meeting, Chair. And another key element will be around looking at how we create the headroom to do all of these things to support that shift in focus, which brings me on to my final point, which is around the challenges that we have been facing in terms of this group analytics work. And the challenges are largely around resourcing and the many competing priorities and demands that are facing all 3 informatics functions. And I'm sure Worcester Acute aren't any different in this respect. I think we've done well to get to where we are with a relatively small amount of investment, and that's been through some extremely hard work by the 3 heads of information and their teams. We've got the impending EPI implementation, which is going to increase the workload of those teams. But there is some additional resource going in to support the EPI implementation. EPR, the electronic patient record, the new patient management system. We've also kind of working on automating, as I mentioned earlier, which will create some headroom, but we need an initial kind of injection of investment to be able to create those reports and automate that reporting. We've also now recruited the group analytics role, which will help with some of the workload going forward. That role will also look at how we share data across the group, because that's quite clunky and creates a lot of workload. So we can look at a way of sharing data in a much more efficient way, which will also help to reduce some of the workload on the teams. We're working with local universities as well in kind of 3 ways. One is around supporting with recruitment. the other element is around short-term capacity, what they can do to provide us with some short-term capacity, and also in the future about how they can support us with some of the more advanced analytics when we get into the realms of artificial intelligence, predictive analytics and the like. The final kind of opportunity, I think, in terms of addressing challenges is Worcestershire Acute joining the group. So the informatics department is really keen to get involved in the group analytics work. They've been invited to the next group analytics board meeting next week, and they will be attending. So that's another partner who we can learn from and share with, and also share some of the workload with as well. So in summary, we've made some good progress and we focus on infrastructure standards and standardisation. We're moving on to look at developing information-led culture. We've got a number of challenges, but we've got a number of plans for dealing with those challenges. And just finish off by thanking the informatics teams across all three organisations for all the hard work they've put into kind of getting us so far. Don't know whether you want to add anything to that, Adam?
Just to reiterate what you said, Hack, I think this is a really good example of how we can work together as a group. We've got different skills and experience, great skills and experience, but different skills and experience in each of the existing three and I'm sure 4 organisations. And what we've really been able to do is bring those skills together, bring different people to the party, and really progress the work. For me, the really interesting stuff is going to happen next as we start talking about culture. Getting the infrastructure and the standards and the reporting in place is obviously a really important foundation. But the next step, getting people to be using data and information in a different way, getting it to be fundamental to our decision making and our planning for the future is going to be a really big cultural step, which I think is going to take a lot of effort from people across the group.
Thank you, Hack. Very comprehensive summary. Thank you, Adam. Any questions or perspectives to colleagues? I think we self-evidently, Hack, I'll allow Sue to go first. Sue?
Yes, thanks, Hack. I've popped it in the chat, but I just wondered if, first of all, congratulations to the whole teams. It's really moving forward. I just wondered whether there'd been any external benchmarking of the capacity and capability in the analytics work. That was my first question. And my second question was, can you see yourselves working with the ICSs to help them to develop in this field? Thank you.
So in the first part of the question around benchmarking and capacity and capability, that's the piece of work that we're working on at the moment. So we're looking at, I think there's a documentation that's come out fairly recently from NHSE and the Association of Healthcare Analytics around what good looks like from an informatics function. So we're looking at what good looks like. We're looking at comparing with others, but also comparing across the group, and not just looking at where we are now, but looking at the skill sets we need moving forwards as well, and how we develop those skill sets. So that's a piece of work that's going on at the moment. So we will kind of feed back on that as we progress that over the next few months. The second bit in terms of ICS's development, I mean, one of the things that is on our list of things to do is around intelligent cells and how we share data across the group around population health management, some of the things we touched on this morning. So I think the part of this is about actually trying to, and data sharing is the other piece as well, about how we do that better in a more efficient way. So those are all things that we need to look at, which we haven't as yet, and it's largely around capacity. So part of kind of what we're trying to do is create the headroom to do that. So those are on our agenda to do, and that'll be part of the discussion around the information-led culture, because I think data sharing and how we work together as a group, but also as ICSs to use data, I think that goes beyond the informatics functions, and that is about how we kind of look at and understand data through a different lens. So that I think be the starting point of those discussions around the ICS, rather than get them talking about the nuts and bolts of intelligence cells. This is about, well, how can we use the data to improve our services, just changing the focus of the discussion. So that's where we're looking to go in our next steps.
Thanks, Zach. My fear, Sue, to be honest, is that with some of our ICSs, it could be a massive cul-de-sac of treacle, trying to get all of the ICS partners doing. It's taken us a long while to compare apples with apples. And I think obviously one of the key things is to get Worcester Acute fully embedded and to learn from them, but so that we are comparing apples with apples across all the bits of the foundation group. Just quickly before we move on, Ian's raised the issue in the chat box, Hack, about the 8 agreed projects. Is there anything for us to be aware of on any of those or not?
Yes, the 2 on hold I've touched on. So it's intelligent cells, and it was something what the other one was now, the data sharing one, I think. So and I've kind of touched on kind of what we're looking to do in terms of moving those forwards. So these and I've in the paper set out kind of where we are in this project. Some of these are quite big projects, so they're not things that you complete in a short period of time. But I think we've done well to get to where we are, and we've got a route to completing the other projects. And I think they are close to completion or they're ongoing. So things like data quality kite mark, even though I'm saying it's not the completed project, we've got a methodology, we've got an approach. It's just going to take a while to apply those kite marks to a number of metrics. So some of these will run for months and months, if not years. But as a project, I'm looking to close down some of these as projects and convert into business as usual over the next few months as well, so we can then start moving on to looking at the information-led culture.
Yeah, no, great, thank you. And just to Worcester Acute colleagues on the line, we in the early months of the foundation group, whilst we were working out how do we compare our data on an apples basis, it was only when we agreed what an apple was in terms of a data set that we then were able to make these proper comparisons you hear us making this morning. So I'd strongly counsel Worcester colleagues to understand what the analytics team have done so we can quickly move ahead in that regard. We will come back to Cerner changes a bit later in the the question's been asked by a member of the public, but I'll just ask it now because otherwise it will be lost. Will the change to Cerner affect any of this, do you think, Adam?
Yes, so it will have a number of effects. So it will change our reporting infrastructure, if you like. We'll be getting the data from somewhere else, and there will be a significant effort involved in re-engineering our reporting, if you like. I think at a fundamental level, though, it should improve our data quality, and it should improve our access to data. We'll be able to report on more things in a more timely way, and that is part of the intention of the new EPR.
Super. It's still a mystery to me, as a man who has not spent his whole career in the NHS, that an apple is not an apple is not an apple in the NHS. I find that absolutely remarkable, but still I'm ensuring that within the foundation group an apple is an apple. Thank you very much for your hard work, Hack, Jane and Adam. We'll move then on to our deep dive into the additional performance measures, in particular theatre productivity. So some really important work going on, I know, on theatre productivity. So before we do get into the deep dive, and I assume Harkamel, you're going to go first, is to thank each of the 3 coups for your leadership on this. There is an enormous amount of opportunity on theatre productivity. We know it's not easy to capture very often, but the opportunity is very real. And if we're going to make real inroads into our waiting lists, we must persevere and succeed on this important issue. So am I correct in saying, Harkamel, you're leading off on this?
I'm not actually. So we're doing what we did last time and doing it all together. So Andy from Wye Valley is starting us off, but don't worry, I have a lot to say.
Well done, Andy, for putting your head above the parapet. Over to you, Andy.
Thank you, Chair. Yeah, you've already stolen a bit of my thunder there in terms of our productivity challenge and theatres being our most expensive resource. We've been working across the foundation group and working across with our operational clinical colleagues around where our synergies are and where our opportunities are as a foundation group in terms of improving theatre productivity. As we all know, theatres is our most expensive resource, And across the group, we've been using the getting it right first time methodology and benchmarking to drive some of our transactional and transformational change as a group. And as already mentioned, we are already part of the getting it right first time, going faster, further programme, and theatres will be introduced to that in the very, very near future. But just taking us through the slide pack we produced here. The first slide here. I won't go into any detail, but just gives colleagues and members of the public the background to our different theatres. I think what is evident here is all three trusts are focusing on ring fencing our elective activity, and that our urgent and emergency care pathway does not impact on our elective ability, and that all three trusts have a strong emphasis on protecting our bed base and reducing elective cancellations to increase operational and, more importantly, clinical confidence that there will be a bed for patients on the day of surgery. All three trusts have a really detailed theatre improvement plan, and there is shared learning, which we will go on to in a short while, with the aim to reduce our waiting lists, reduce our long waiters, and reduce the reliance on outsourcing, insourcing, and the vanguard theatres that are both at Swift and Wye Valley. And we've got very detailed productivity plans behind that, and there's lots of work ongoing. Again, the next slide, I won't dwell on overly, but that just gives you a summary of the comparison between our three trusts and the theatre activity and sessions compared with Q1 1920, so pre-COVID, and what we've delivered in Q1 this year. I think there's a sort of health warning on this, that there is various factors why our activity is behind 1920, but also why the number of sessions are lower than 1920. Changes to theatre templates, increasing our emergency theatres or trauma theatres will have an impact. Additional bank holidays that weren't there in 1920, and of course, as already mentioned, the impact on industrial action. And in terms of the case mix as well, and theatre maintenance, which George Elliott alluded to over their Q1 period as well. Case mix is also an important factor here. All three trusts have been trying to maximise our theatre productivity and theatre case mix to ensure those larger cases are done in theatres, and those smaller cases that can be done in minor ops rooms are also capitalised on. So that's why there is a difference in some of the case mix, but also because of the current waiting list positions in all three trusts, which weren't there pre-COVID. Patients are more complex and potentially needing more time in theatres because of the waits they've had. And lastly, from me, before I hand over to Harkamel, and what Hack and Adam has already referred to, and Russell, you've already mentioned, agreeing the apple. This is one of the apples that we have agreed, and that is our definition of a capped theatre utilisation. That is in line with the getting it right first time measurement. So all three trusts now have signed up to and agreed that the theatre utilisation that Harkamel will refer to later is now, and is in our integrated performance reports, is all measured in exactly the same way. So Harkamel, over to you.
Thank you. So going to the nuts and bolts of it, our theatre utilisation. So it's a really interesting piece of work in terms of trying to get this comparison together, but also reconcile what all those definitions look like. So I think for us at Swift, that's really important because we used to report uncapped theatre utilisation, and both have their merits. It's just that we, as you sort of allude to, we need to be comparing the same thing. So for George Elliott, they ended June at 65%. For Swift, we were just above 85%, and for Wye Valley, they ended July at just above 78%. And it's been really important to try and make sure that we are all using the same definition, which is why we've presented this data, and moving forward, all our IPRs will reflect this definition. But in doing so, we've really realised that actually the validation is really important, and it's really vital that we all understand what we're including. And we were really clear that we wanted to present something accurate here today. And what we have seen is that at George Elliott, there has been an increase from when you look at the position from January 2023 to where we were in April. And although there's been a slight decrease moving forward, we will come on to it, but there is an action plan of how we're all going to work together to try and improve that. Swift, this is our capped utilisation, so colleagues will be used to seeing slightly higher figures because we used to report uncapped utilisation. But we are at 85% there or thereabouts, and that remains stable. But we do know that we have some specialties where we need to focus on. So ophthalmology, there's some opportunity there to improve our utilisation, and in ENT. And over at Wye Valley, issues were identified, and this will be a bit of a theme for 3 organisations in terms of real-time data entry and functionality of our systems. And we need to really make sure that we are building confidence in the data for our clinicians and also for our ops teams. And we know that for all 3 organisations, there is additional work still required with this scheduling at a specialty level, and making sure that we're all embedding the 642 model of booking in the same way. We've also been working really hard behind the scenes to make sure that this is reconciling with the numbers that people see in Model Hospital and GERD, because many of you will see reports from different places and it doesn't always reconcile with the numbers that we all give you. And a big piece of work in providing these figures that we wanted to share with you today was to try and understand how we get back to that. And in terms of the GERD number, we are there or thereabouts. We were probably the biggest outlier at Swift because of the uncapped versus capped theatre utilisation. Model Hospital has been slightly harder, partly because it's quite out of date. And so by the time that we're then trying to reconcile where we are, just doing that piece of work has been more challenging. But we are meeting with an analyst who provides some of the information to Model Hospitals to understand their processes and data quality. And then the 4 organisations will be able to make sure that we are reconciling things in the same way, so that at least there'll be consistency. So no matter where you see the data from, be it an internal or an external source, it will be similar. So moving forward, we looked at a few themes. Essentially, improving theatre utilisation is about robust accountability and strong governance arrangements. And given that it's our most expensive resource, it's really important that our teams are empowered and our services are geared up to solve problems on the day. If you don't solve the problem on the day, you've already wasted the resource. So we looked at a few key things that we could look at there. I'll come on to 642 in a moment and pick that up in the comment. But it's really important, as I've alluded to as well, that we have data-driven change, and that's certainly what the GERFT methodology brings up. So late starts and early finishes are a real classic of where you'll start looking at to make sure your theatre productivity and theatre utilisation is where it needs to be. So for George Eliot, there's been a steady improvement in lists starting on time. And that's been a comprehensive effort across the directorates, and a lot of work on some of that cultural change and people buying into this. If the clinical teams are embedded in this, it's a lot more likely to happen. And that whole bit about focusing on getting the data on the day and the processes on the day right really supports with that. And then at George Eliot and with us, the focus on not finishing early or not finishing too late is really important. And at George Eliot, there was an increase in May in terms of lists not finishing early. And there is some correlation into the industrial action with that. At Swift, there's been a small improvement in main theatre lists starting on time. And across all theatres, there's been a 6% reduction with lists finishing early. When you compare Q1 this year and Q1 2019, but there has been a small increase in lists overrunning, which is an area of focus for us. We know that theatre recruitment is really hard, so what you do not want to do is have lists overrunning so people can't get home on time, and work-life balance is significantly impacted upon. So that's something that we're really focusing on at Swift, and we're picking that up as part of our Excel in Everything programme. At Wye Valley, they ran a really comprehensive, really big, impressive theatre improvement event, which Robin and I have thought about replicating in some way to try and improve our utilisation. And issues were really identified with that real-time data entry, and we would say the same at George Eliot and at Swift. And getting that data right is key to making some of these improvements that we need to make. And actually, when you're then challenging the teams around the list not starting on time, if the data isn't robust, you'll lose people quite quickly. That said, there were some patients in some specialties where it is recognised that it takes longer to anaesthetise. So, for example, all surgery patients or learning disability patients, and making sure that we schedule accordingly is really important, both for utilisation, making sure that you don't under or over schedule. And then moving forward, into on-the-day cancellations, where we have talked about before. So the definition for this is any patient who is cancelled on the day of surgery for any reason, so be it clinical, non-clinical. At George Eliot, hospital cancellations for non-clinical reasons are generally due to bed shortages, due to the increased emergency demand, and we heard some of that earlier. At Swift, we do have challenges in recording some of the data, but that's predominantly around understanding what the reason for a clinical related delay is, and also whether there are any non-clinical. We don't get very many of them, but we don't really have the data to sort of back that up. So we've been doing audits to, in the same vein that the theatre improvement went at Wye Valley went. And at Wye Valley, doing the escalation process to support the avoidance of cancellations on the day and improving the functionality of the system, as well as the data quality issue. As a group, we've agreed to adopt operational ring fence. So I've been really keen to learn to share some of the process that we have at Swift, whereby we do not cancel any electives for bed-related cancellations. And if we were ever in that need to do so, we've already agreed that it would have to be lots of execs sort of agreeing to it. And sharing some of that cultural work that we've done to sustain that has been really, really useful. There's also the review of some of the pre-op guidance and making sure that the instructions to patients are as clear as they can be to reduce any clinical or patient-related cancellations. And also really looking at what our digital offer is and making sure that the patient reminders are there and what that two-way texting functionality within some of the pre-op looks like, and trying to make sure that patients are fully informed. We've also, Andy mentioned before, got a Vanguard on site, and we've introduced a new way of reminding patients and also asking patients to have increased flexibility. So where we do have patients who are cancelled on the day for clinical reasons because they're not fit to proceed, we have then a list of patients who are ready and have, not eaten anything, so starved themselves in readiness, and we can ring them at 8 in the morning to ask if they could then join the end of that list. So actually, we haven't lost any of that very expensive capacity, which has been a real success for us. So I'll pass over to Robin.
Yeah, thanks, Archimel. The next few slides just really show the depth of the work that's gone on. So Andy's just flicking through slides 9 to 15 in your pack that just show through for each of the organisations. These are some of the snapshots of some of the key actions that each of the organisations are taking individually. But the work that's been presented here is the way all of that has come together, and that cross-fertilisation of conversation at many levels within the operational teams in order to capture the key points of learning from all of the work that's gone on, because each of our projects, each of our programmes of work and audits has been slightly different, and therefore we have all captured slightly different elements, which is real richness to the way in which all this comes together. And so slide 16 that Andy's showing now is just really a summary of some of the solution themes that we pulled together, the commonalities out of each of the pieces of work that have been done. So that flow through the right procedure, right place audits, making sure that we're getting the right patients, the low complexity patients that can be done in procedure rooms, being treated in procedure rooms and not in theatre, making the theatres available for the more complex cases, and therefore driving the efficiency in terms of the impact on our waiting lists. Also, the focused recruitment on retention for staff. We know staffing in theatres is a key issue for all of us and nationally. And it's about the way in which we work together and look at how we develop our own internal models of growing our own apprenticeships. We've got some good examples of ODP apprenticeships across the group, etc., that are generating success. Likewise, it's been mentioned 642. Just to answer the question from the chat, the 642 is the booking process system that we use in theatres, quite widely used across the country. So at 6 weeks, the theatre schedule should be locked down, so we know exactly which theatres are running on which days. At 4 weeks, we've got patients then confirmed and booked into those lists, so the theatre teams and the surgeons know exactly which patients are presenting on those days. And at 2 weeks, there's a final check that those patients are all fit for surgery and can proceed, and the list proceeds as planned. So that's the very high-level summary of the 642 process. The other themes around the continued improvement programs, we've said Mission Possible at George Eliot, Excel in Everything at Swift, the audit that took place in Wye Valley, and likewise that preoperative process that Harkemar's already alluded to, which was around the my pre-op system that George Eliot and Swift have progressed to date. And therefore utilise or trying to aim for minimum cancellations and improved efficiencies. And linking back to the previous slides from Hack and Adam around the dashboard development, that enrichment of data to ensure we've got a common approach and we spend more time resolving the problems as we do debating the data, and that maximisation of clinical ownership. They're all common things that come out of the conversations that our teams have been having within our individual organisations. So moving on to the final slide, just talks about some very high level next steps, which is around to mention our involvement with the model hospital, with GIRFT, with Further Faster, and we attended a meeting of the national team last night to compare where we got to, and a really energised meeting and really positive in terms of the developments there. Which will pay huge dividends of getting more patients through our services in a faster time scale. Likewise, we've also looked at appointing a group data analyst to start to bring some of the cohesion to some of the data analysis that's required as we progress more into this journey as a group approach to the way in which we're resolving problems. I've already touched on my pre-op, but there's a couple of examples there of where we're seeing specific learning from each of the organisations that's really helps, and it will benefit all four organisations now. From Worcester as well, as they join, we know that I know personally they've done a lot of good work in terms of theatre efficiencies and utilisation as well. And likewise, the provision of mutual aid will continue with that, and to maximise the utilisation for the benefit of not only our own health economy, but the wider economy too. And I'll stop there, Russell, and take any questions.
A really great presentation, team, and really great to see that level of collegiate learning and sharing. Lots of chat in the chat box about the need to make sure that we are learning fully from Worcester and that they're learning from us as well. Questions and perspectives, Glenn?
Yeah, that was really interesting, and kind of reinforces the fact that there's a big opportunity here, and that we're not helpless. Because I think sometimes we do look at this kind of, it's urgent care gets in the way and we cancel elective work, and if only we didn't have the urgent care. But actually, beneath the surface of that, there's a lot of opportunities for improvement that are nothing to do with the impact of urgent care. It does reinforce the need for us to absolutely make sure the data is accurate, because obviously it's all based on that. And there's nothing more irritating for me than when I'm chairing elective recovery board at regional level and see our numbers, and I'll go back and say they don't look right. Oh no, they're not right. So we just need to make sure our numbers are right. And that kind of takes me to what with reliable data, that level of clinical engagement is important for me. So if I was a surgeon working in any of our sites, would I know what my data is like? And I do wonder whether percentages are the right way to express it. And I wonder whether if we could get an indicative cost per minute type indicator as to, if you present a league table, just put it up on the wall in theatres about how much financial waste there is by individual list. That might tease out some of these problems, because obviously we're looking here at averages, and some of the averages are pretty good, but beneath that there's quite a lot of variation between specialty and between clinicians within specialties. So I'd encourage you to try and present it in a way that encourages them to do better where they can.
Thank you, Glenn. And any other questions or perspectives to colleagues? Can't see any hands up. Just a couple of thoughts from me. Some of us will recall the name Dave Brailsford, who was the guy who used to run Sky Cycling during the glory years. And Brailsford's whole focus was on a number of tiny improvements. Just a 1% improvement in a lot of things adds up to a big improvement. And I think that's definitely what I'm hearing in spades from you guys, and I'm absolutely delighted with. Well done. I do still wonder, though, that we're missing a paradigm shift in terms of productivity. As you've heard me rattle on about, the evidence is clear. The same surgeon in private practice, in his NHS work, he will be 30 to 40% plus more productive in his private work. And there are a variety of reasons for that. There are no do not attends, as an example, in private work. I am absolutely delighted that Ellie Bulmer has joined us as a NED down at Wye Valley. Ellie used to be a hospital director at Nuffield Health. I would counsel, particularly you, Andy, to spend time with Ellie, just to make sure that we're not missing a paradigm shift opportunity in this. I think Glenn's idea of the way we describe the sort of losses on this is enormous. But at the end of the day, those surgeons who are doing private practice, it is also about how we engage them in how they can bring all the learnings they have from what they do in their private practice in terms of productivity into into their NHS lists. Because I do wonder where there's still a paradigm shift. As we know, private work, you're paid piecemeal. NHS work, you're paid block. Is that part of the issue? I think there's still a missing element in our understanding on this, despite the phenomenal work which you guys are all doing, and I'm really delighted with. But we need to make sure Worcester comes on. Marginal gains theory, indeed, Lord Burley. Marginal gains theory, indeed. Okay, team, so we'll move on then to the safe staffing overview to include nurse per bed ratios. My Director of Nursing, who's going to lead off on this?
That's me, Chair, if that's okay. And I'm going to lead us through, given we've only got 10 minutes, I'm going to lead us through the whole presentation, and then clearly Natalie and Fiona are here to help with any questions that colleagues might have. We decided on safer staffing to focus on nurse staffing in particular this month. And as I say, for expediency, I'm going to go through each of the slides, and we weren't proposing to share the slides given that they've already been circulated in the pack. Just going to cover a little bit around strategic context around safer nurse staffing, a little bit about evidence-based tools, some local benchmarking that we've done across George Eliot and South Warwickshire and Wye Valley, a little bit of benchmarking from model hospitals, so some national benchmarking, a little bit of information about our own workforce, so particularly around vacancy and use of temporary workforce, and then just in terms of what we want to do collectively across the group in terms of next steps. So safer nurse staffing really came into the fore post the Mid Staffordshire and staff inquiry. A number of documents have been published as guides for, sorry, somebody not on mute.
It was Fiona, I think, but she's forgiven. Back with you, Lucy.
A number of documents published that just act as guides for making decisions about safer staffing, particularly in the context of right staff with right skills in the right place at the right time. But how do we as chief nurses and senior nurses in our organisations determine what's safe? Well, there's lots of guidance out there to help guide our decision making, the specialty specific guidance, and we list a few in there, such as the BAPM standards for neonates, the GPIP standards for critical care.
Lucy, if you hold on for a second, I'll find out who's come off mute.
Oh no, that was on this morning. I think it's safe now.
Okay, I've muted everyone, including you, Lucy, so apologies for that. Back with you.
Thank you, I've come off mute. So lots of guidance out there. And then there's the national publications, such as the National Quality Board Guidance, and more recently, the Workforce Safeguards from NHS Improvement. What all of these documents have in common is that they refer to the use of evidence-based tools to guide decision-making, but that has to be in conjunction with professional judgment of senior nurses and has to be in the context of clinical quality indicators and outcomes for our patients. So why would we use evidence-based tools? Well, one of the criticisms of guidance that existed during the mid-staffs and prior to mid-staffs was that staffing was assessed based on staff to bed ratios. And we all know we don't look after beds, we look after patients, and patients have differing needs. And therefore, the evidence-based tools enable us to measure that level of need of our patients. It looks at case mix, it looks at acuity, it looks at dependency. And as a minimum, we're required to audit twice a year, once in the summer and once in the winter, because we know that case mix changes seasonally. And then the tools guide us and they recommend the staffing requirements based on the case mix and the patient need that's derived from that audit. As I say, the tools alone are there purely as a guide because there are lots of other measures, which is where professional judgment comes in, that play a factor in determining safe staffing levels. And that will include things like your ward layout, the number of side rooms, the sort of medical cover that ward has, whether that ward receives direct admissions or whether it receives admissions that have come through another unit first. And all of these factors have a role to play and can't be built into evidence-based tools. So part of the national guidance refers to comparing your staffing with peers. So that's what we've done in the table that talks about staff to bed ratios for comparable wards at George Eliot, Swift and Wye Valley. So what the table shows is our ratio of registered nurses, nursing associates and healthcare support workers to our beds. And it takes it down to a single unit because clearly our wards are different in number. So in order for us to be sure we're counting the same things, we brought that down to a single bed. And we've selected those wards where we know the specialties are the same, and therefore the case mix is likely to be similar, but won't be exactly the same for all of the reasons I've just described. And what you can see for those comparable wards across George Eliot, Wye Valley and South Warwickshire is that our staffing is broadly comparable. We've excluded any specialist areas from that. So these are our general surgical, general medical wards and frailty wards. So our staffing is broadly comparable. There's nothing for us to do a deep dive into in there. As part of this exercise, we did include Worcester Acute, some informal benchmarking with them, but given they've only just joined the group and haven't been able to validate the information and agree that the wards were comparable, we haven't included it in the presentation. Just want to turn us to national benchmarking. So there is limited benchmarking available, but in Model Hospital, we can access care hours per patient day. We include a graph there which does show George Eliot, Swift, Wye Valley Trust and Worcester Acute. And we've included that because it's publicly available. What the chart shows is trust level data. So this is not ward level, although it can be drilled down into ward level data. So it shows trust level data of the care hours each patient receives each day, and I'll talk about that a little bit in a minute. And it just shows where our trusts rank in terms of bottom quartile, top quartile or mid quartiles. As I say, it's trust level. Can't really derive much from trust level information, but we can break that down to ward level. We can have a degree of confidence. We won't necessarily be counting apples with apples, but we can have a degree of confidence that the information that's counted and within the model hospital is that we are counting the same things. And that's because the National Quality Board guidance is very prescriptive around what we count and what we include in that return. And just for members of the public and for our non-executive colleagues, care hours per patient day broken down at its simplest level is if you had one nurse for 24 hours caring for 10 patients, each patient would receive 2.4 hours of care hours per patient day. And essentially, you can, as I say, you can look at that at ward level, you can benchmark and then see if your staffing and care hours that your patients receive are at the same level as other hospitals and peers. That information is derived from something that's called the NHS England Staffing Return. And in the pack, you can see the staffing returns for George Eliot, Swift and Wye Valley Trust. And just so colleagues understand what's included in the return, essentially the return says how many staff do you plan to have on duty providing direct clinical care to your patients, broken down by registered nurse, nursing associate and healthcare support worker across day and night. And then what actually happens, because clearly people will go off sick, patient need might increase and you might book more staff above your plan. And the difference between the plan versus the actual gives you a percentage fill rate that will either be above plan or below plan because real life happens and patient case mix changes. And that then drives the care hours per patient day because it's based on the occupancy of beds taken from what was in the olden days called the midnight return. So how many patients were in those beds at midnight? The reason you've got 2 tables for each trust in the pack is that the left-hand table in the pack for each trust is around if we'd staffed at our plan and nothing changed and all of our beds were occupied, what would our care hours per patient day look like against our establishment? And then the right-hand table is the reality of what happened in April when our staff either went off sick or a patient case mix changed. And as you can see, those things just drive different care hours per patient day and would enable us to go and drill down into further detail and compare ourselves with peers within the model hospital. Also included in the pack for you to take away at your leisure is just information around our vacancy factors for registered nurses, midwives, healthcare support workers and nursing associates. And clearly you can see there are differences across those staff groups and across the foundation group. But we all know that we must focus on our recruitment and retention strategies and growing our own, because we know that having substantive established staff caring for our patients provides safer, better care and better high quality care and better value for money for our patients. We also include in there just our use of temporary workforce. We know that temporary workforce is high, particularly agency across the foundation group. We're all driving hard to reduce the use of temporary workforce and in particular agency, because it is very expensive. And as I say, it doesn't provide high quality care, continuity of care for our patients, but neither is it great for our staff who would prefer to be working with their own colleagues each day. We also include in the pack for you to take away and look at just some of the incidents that are reported across the group in relation to staffing. Some of the national guidance, again, is prescriptive about those types of incidents where we should report concerns over staffing, particularly where patients don't receive care in the timely way that they should. We know that these incidents are underreported, and that's because when staff are really busy, the last thing they're going to do is report incidents, because they will be providing direct patient care. We talked earlier about using evidence-based tools, making sure that the findings of those are then considered in the context of professional judgment, but then aligned to and triangulated against quality metrics. What we have as we were working on this and pulling this together and in our other discussions around ward accreditation is we have a plethora of quality metrics, performance measures, but we don't have them pulled together in one place. So one of the things that we really want to do as we work together as a foundation group moving forward is to come up with a single quality dashboard across the group that we could use for the purposes of triangulation. And finally, for me, just some interesting things that we pulled out when we were looking at this was headroom is built into our budgets. Now, headroom, again, for non-exec and public colleagues, is what's built into the budget to cover for annual leave, sickness and study leave to ensure that our patients receive the same level of care 24 hours a day, 7 days a week, 365 days a year. Carter recommends that headroom as a minimum should be at 22%, and you can see the headroom across our staff groups and across the foundation group included in the last slide in the pack. Now, we know from our own analysis that actually 22% might not be enough, particularly if we are to grow our own workforce, have more learners in the workplace and provide support to their learning and education. And clearly, if our retention strategies do what they're aiming to do, which is to retain staff for longer, our staff will be on maximum annual leave, which then clearly has an impact on headroom. We also just looked a little bit around supervisory time, because again, in order to recruit, retain our staff, manage sickness, etc., it's important that our ward sisters are given sufficient supervisory capacity to be able to support learners in the workplace and to be able to discharge their duties. And you can see there's a difference. So at South Warwickshire and George Eliot, ward sisters are supervisory 40% of the time, and at Wye Valley that's 60% of the time. And we want to do further work on headroom and supervisory time in the context of our recruitment and retention strategies moving forward. And we'd clearly like to do some formal benchmarking with colleagues at Worcester Acute now that they've joined the group. Sorry, that was a whistle stop tour. Fiona and Natalie, have I missed anything?
I don't think so, Lucy. You've been very comprehensive.
No, that was great. Thanks, Lucy.
I've got a question to ask, but any other questions or perspectives, Glenn?
firstly, it's great to see that you're collaborating on this and getting into the detail of it. I may be about to expose my old accountancy skills as being somewhat out of date, but can I just check on slide 6 of 22, when we talk about staff to bed ratio, that end column, shouldn't that be the number of trained added to the number of non-trained? And therefore, shouldn't it add up, for example, on Y Valley to 0.27? Because if it does, there is a material difference, but I may have read it wrong.
Okay, do you want to take that away? That's the homework question. Any other questions or perspectives? Great to see Robin diving in and out of his screen, Natalie. Simple question, which is, I think, the question the members of the public would want each of the directors of nursing to answer. And I know you hate me asking these questions, so you can guess what I'm going to say. Do you feel, Fiona, in terms of our nursing ratios, that we are safe at Swift?
Our budgeted numbers are safe, but as Lucy was pointing out, there are times when our budgeted numbers are very different to our actual numbers, and that is the task of the ward manager, to manage that sickness and the absentees and the vacancy position, and that's really why we focus some of our on Lucy's conversation and our presentation on that, because this is not about how much you've got budgeted. It's about retaining, keeping your staff satisfied, keeping them at work, growing them and developing them, and having time and sufficient resource to do that. And I think at this particular time, when we know that retention is difficult and recruitment is difficult, I think it's even more important that managers not only are developed in terms of their leadership skill, but their management skill as well, and have time to do that.
I get all of that, but if I'm a member of the public, what I think I've heard you just say is, on occasion, we're not as safe as we would like to be, but most of the time we are safe. Is that fair?
It's a challenge sometimes, yes.
Okay. Natalie, or Robin, as you are on my screen, would you concur with that?
Yes, I would, Russell. And I think it's also just poignant to put in that within each of our organisations, what you then have is you have a staffing huddle every single day to ensure what's happening across the organisation, where the acuity is, and if we have to make moves, albeit that we don't always want to do that, we make things as safe as we possibly can. So sometimes the staffing levels on the wards are below the planned, but we ensure that we have that cross level of safety, that we have that level of our own staff distributed across the organisation, so that we can support the temporary staff, but also so that we know that the standards are being met. But yes, it is a challenge, just as we heard from an operational point of view with the capacity and activity. Staffing is a challenge as well.
Yeah, there's no problem saying staffing is a challenge. On occasion, we're not as safe as we'd like to be. Lucy, is that your position as well?
I would agree that our baseline levels are safe, that they can be challenged at times for the things that Natalie and Fiona have alluded to. I think the thing that's changed significantly, particularly at Y Valley, in the last, I've been here for 6 years, in fact nearly 7, is actually the skill mix on the wards is more dilute than it used to be, and that's partly because we're doing exciting things like growing our own nursing associates, but they take some time on the job to learn, and we've relied very heavily on international recruitments here at Y Valley. Now those nurses come with an awful lot of experience of nursing in their own country, but adjusting to working in this country is particularly difficult, and therefore the skill mix is more dilute, which can lead to a challenge, which is why we were talking about sort of that supervisory time and having sufficient time for people to learn how to do the work on the job as well. Thank you.
I understand, Lucy. Thank you. Thank you, team. Keep up the great work. And I know you're being supported, particularly by HR colleagues, in terms of retire and return, staff satisfaction and everything else. So thank you very much. Really comprehensive report. Great. I think we're on to any other business before we go to questions from members of the public. Any other business from colleagues, please raise a digital hand. I can't see any digital hands raised, so we'll go then to questions from members of the public. Sarah, do you want to come online? I know we've had a few questions, and thanks again to Chris from Wye Valley, who is always fantastic at asking a variety of questions. Chris, I know sometimes you feel embarrassed about the number of questions. I'd far prefer to have too many than too few. So Sarah, over to you.
Thanks, Russell. So we've had a question from Roger Lloyd, who is a public governor at Swift. And Roger asked, in the light of the increasing number of A&E attendances, what insight has the analysis of the causes of attendances shown across the group? And I think the chief operating officers are going to answer this, Russell. Thank you.
Okay, if we can rattle through these guys, because I think we've got 5 questions and I've got 1 hand up. Harkamel, you first.
Yeah, so we have done analysis to try and understand the cause, and what I would say is that there's not one big thing that's just driving anything. It is partly seasonal, but partly just a growth across everything. So we're working with ICB colleagues to make sure that we're working effectively with primary care to signpost where ARTS patients could go and get support. But we do that analysis, and we share it on a monthly basis with the wider team to see if there's anything else we can do.
Okay, thank you. Robin?
Yeah, thank you, Chair. So the one area over and above what Harkamel's already responded to for us is particularly around the level of patients who are coming in who are critically sick. And so I'm putting a lot of pressure on our intensive care services as well. So that's one area of focus for us, and a particular cause for concern on days with our site team and clinical teams as to how we manage those flows. So for me, that's showing that we're not over admitting and admitting patients who wouldn't ordinarily need to be admitted. The numbers attending ED are high and resulting in higher numbers of admissions, of appropriate admissions, which I think is important to note.
Okay, that's a key point. Thanks, Robin. And Andy?
Chair, yeah, I would agree with what Robin has mentioned there. We've seen higher acuity in RED in recent months, and again, high levels of attendances. I think we've also seen sort of the post-COVID impact leading to a backlog of health issues, both physical, medical and mental health, along with that post-COVID social and wellbeing issues as well. So I think we're seeing a multitude of issues that is resulting in our high ED attendances, along with, and we're doing some further work on that, is there a correlation between our long wait and elective patients and an increase in our urgent and emergency care pathways as well? I'm sure there is a direct link there, and we're doing some work on that locally, because obviously the challenges in Herefordshire in terms of long waits is greater than our colleagues in George Eliot and Swift.
Okay, just I'll take over from Sarah because I know she's got a poor throat. Jana, I've got at least five more questions, so I'll come back to you later if I can. The next question is from Chris at Wye Valley. This is again for the Chief Operating Officers. What is the average waiting time for children who need dental surgery in each of the 3 hospitals? Did you know this, guys? Or I know we've only just got the question. So, Harkamel?
I only have one patient waiting for dental surgery, and that patient is at 14 weeks, and that's a patient choice. So we don't have a wait for dental surgery per se. We do have a wait for orthodontics, but not for anyone waiting for a dental procedure.
Thank you. Robin?
Yeah, again, the paediatric work we do is very limited, and it's specialised work specifically to children with special needs. The longest wait we have for a child is 50 weeks, but there are additional lists being put on so that wait is brought down, and that's all in plan.
Okay, thank you. And Andy?
Yeah, our wait for oral surgery for paediatrics, the first outpatient is at 18 weeks. For inpatient surgery is at 30 weeks. We do have a couple of patients over 52 weeks, but there's a plan in place for those over the coming month, over the coming 6 weeks. So an issue, and we also have issues with our orthodontic pathway, which we're working across the ICS to resolve.
Okay, super, thank you. So Chris, as ever, when he asks one question, asks subsets. And this is, I think, for you, Andy. The figure in the report shows that all 3 hospitals has increased pressures in their emergency departments. Why is the Wye Valley 4-hour standard significantly lower than the other 2 hospitals? I think we've touched on this. And when will the UEC plan start showing improvements in the 4-hour standard for Wye Valley? I think we've touched on that pretty much in Jane's introduction, so I'll take those as previously covered. Then his next question is, what is being done to enhance endoscopy capacity at Wye Valley?
Yeah, thanks, Chair. I can answer that. We've seen significant issues of our endoscopy workforce this financial year. We've had a couple of resignations in some of our endoscopists, which have now been filled, and they will come into post both an upper GI and lower GI consultant over the coming months. We've also got additional funds through the Cancer Alliance to support additional activity for this year, and our teams are working through that at the moment. If you look at our endoscopy capacity for June and July, as we started to get up to full strength with our workforce, we're 1% behind where we were for 1920, so a handful of cases behind. So we are catching up. The beginning part of the year was a struggle because of the high levels of absence and resignations. We're also looking at workforce review in endoscopy and looking at more non-medical endoscopists as we go forward, but we will see an improvement in our endoscopy capacity for the remainder of the year, all being well.
And the next question is, the situation of the number of patients occupying beds when fit for discharge is a considerable concern. The comments regarding non-Herefordshire patients is noted and added to the concerns. What assurances can the board CEO give that there will be significant improvements in this area before the winter pressures start? Just before I pass over to Glenn as the CEO or Jane, what I would say, Chris, is what I can assure you of is a phenomenal amount of work going on with Place Partners in a whole variety of different areas. I'm really delighted with the work that goes on in One Herefordshire to create a new way of working together. But we are pushing water uphill at the moment, and that's part of the challenge that Jane alluded to in her introduction. Glenn, is there anything you would want to add?
Yeah, I mean, I think one of the things I'm more comfortable with across the group is the robustness of our data. So being clear about where patients are in their pathway, and I think I don't think we could have said that a few months ago. So I think generally, when you look at this across the NHS, the organisations that have got a tighter grip on it are actually reporting higher numbers of delayed discharges because they know where they are and those clinical decisions have been made. In fact, there's quite a lot of organisations who are reporting very low numbers that would tell me that patients are therefore not being identified as ready for discharge at the right point. That said, those patients need to be in another setting, and we're very focused on that, and that's why it's one of our 5 big moves to look at supporting the domiciliary care market. And we touched on that work earlier, and that's going well, both in Warwickshire and in Wye Valley. The other bit, which Sarah Jane spoke about really well this morning, is the focus on trying not to admit some of those more complex frail older patients in the first place by taking services to them, whether they be in care homes or in homes. And using virtual wards, etc. So I think there's a lot more that we can do on that. So I think rather than what is often the case is a kind of focus on if only this part of the system, social care, could do their bit better, which is often what people say. I think we create a lot of these problems through the pathways of care and create a lot of dependency on long-term packages of care by keeping these patients in hospital too long or admitting them when we shouldn't. So I think there's still a lot of work to do, and our winter plans will be built on our urgent emergency care plans that we have in each of the organisations in each place, that will seek to keep those numbers to a minimum as we go over the winter. We've also been looking at 7-day service capabilities in each of the trusts as well, and I think that's a key feature, because we tend to just look at snapshot numbers here, but if you look at the profile over the 7 days of the week, you start to see those opportunities where we could be discharging more patients at weekends, or not admitting patients at weekends because the pathways aren't there to do other things. So I think there's still a lot to be done on it. Sorry, long answer.
No, very comprehensive, very helpful. Thank you, Glenn.
Thank
you. I'll move on then to David Carr as our final question. So, David, what would you like to ask?
Thank you, Chair. It's not a question so much as a comment and a thought that our new friends and colleagues at Worcester Acute joining the foundation group, as someone here who expressed concerns about when the George Eliot joined the group, I would just like to assure our friends at Worcester Acute that they're joining a really good, happy family. Thank you.
Okay, thank you, David. I'll give you the fiver later. And I think that brings our meeting to a close. I'm delighted that so many members of the public joined us. I think our next meeting is in November, he said with a little bit of hesitation. Get my maths right. September, October, November, that's right. So, thank you, Sarah. So in the meantime, I say goodbye to members of the public, and I would ask colleagues to join me in the confidential section in 10 minutes, and I'll try and catch up a little bit of time. Thank you all very much. Thank you for your hard work. Members of the public, I think if there's one thing you can be assured about from this meeting is the combined efforts of the now enlarged foundation group are being applied with vigour to ensure that you get the best service you can, particularly as we approach the challenges of winter. Thank you very much, and thank you very much to all the frontline teams. See you soon.